Hi, I'm Ann Crow with Precision Physical Therapy. We're going to do a virtual running gait analysis for the fourth runner who submitted his videos. And we'll start with a side view. The first thing we're looking for when the runner comes into the screen is the foot strike, so what's happening at the foot. And here on the right leg we see a really nice foot strike to start out. So we see that he's landing foot flat with a vertical tibia. We notice he's landing in some knee flexion. And then as he continues through his running gait, he gains a knee flexion. So that knee flexion increases. And his knee does not travel forward of the foot. His knee is pretty well over the foot. Then on the other side, we see a nice foot flat landing again with pretty close to vertical tibia. In terms of his swing phase, we see that the tibia comes to horizontal in swing phase. So maybe a little past that, it looks really good. And then he has a nice amount of hip flexion as he comes through to toe off here. So good hip flexion in swing phase. So that foot flat pattern and vertical tibia are correlated with lower rates of injury. As we move further up to the pelvis, we see that during hip extension, he maintains a little bit of anterior pelvic tilt throughout his running gait. So we don't necessarily see that increase. So the pelvis is angled a little bit forward in his running gait, and it stays in that pattern all the way through toe off. So he continues to have this forward angle. It appears to me that he has an increase in extension throughout his back. So he appears to be using the muscles, the paraspinals that go all the way down the spine, pulling him into an extended position throughout the spine. That's something that can be bothersome for the low back. When people have discomfort because of that, usually it's low back discomfort. In terms of how much vertical motion we see, he appears to bounce a little bit with his running, but I think that's because the camera is so far on the ground. If we see from his lowest point to his highest point, it does not appear to be more than 2 to 3 inch difference. As we move up the body, we notice the arm swing. He keeps his elbows a little bit behind his body, so he is moving in the shoulder. So here the shoulder's at most extension, and so we see, the shoulder at more extension there. And as he comes forward, he does bring the arm closer to midline, of the body, but it's still a little bit extended. And he keeps his elbow in a whole lot of elbow flexion the whole time. So while he's running, he is not moving at all into elbow extension during his arm swing. And so generally we would like to see that the hand comes a little bit lower, maybe even down towards the hip. When he's running, he's carrying a whole lot of tension between his shoulders, in his upper back, and in his arms. And the tension he's carrying there is making it so that his arm swing is maybe a little less effective. Additionally, you can see, the shoulders are drawn together, and we'll see that in the back view. But that does contribute to this posture in the spine of extension. And when you think of the body's trying to maintain stability in the trunk, so if you're using the paraspinals and the scapular adductors to maintain that rigid portion of the trunk, then the ribs tend to flare out a little bit, and the abdominals may not work as well. Additionally, if you increase tension in the upper back and shoulders, you have to have rib expansion somewhere in order to breathe well. And so a lot of that rib expansion may be coming, from the lower ribs, encouraging the abdominals to relax. So that's the shoulder and trunk reason he may be in some of this extension in his back. And some of that extension in his back may have to do with the over-reliance on the spinal extensors for trunk stability. Because he stays in a little bit of an anterior pelvic tilt, which we talked about being this direction, throughout his running gait, it's possible that there's stiffness in the hip flexors. It's something we check in the clinic. He stays in that posture the whole time, so there's no clear indication of hip flexor stiffness or shortness. It'd just be something we'd have to test and see if it's present. If it is present, then the pelvis sits like this. The hip flexor attaches down this direction. So as the leg goes behind him, the hip flexor could be pulling his pelvis this direction, which would be another reason the abdominal muscles may be relaxing a little bit for this athlete, and allowing his spine to extend into this posture. So there could be a reason from the shoulders and from the hips. I feel more confident about what's happening in the shoulders and the upper body than necessarily at the hips, just since he doesn't move into and out of the anterior pelvic tilt, he's sustaining it. That's everything I wanted to see from this view. So let's just double check on the other side and see if there's anything different we see from the other side view. So here we see foot flat pattern again. Foot flat pattern, vertical tibia, nice knee flexion and swing phase. And I just want to point out, watch, as you notice his hip and knee bend at the same time. He's doing a really good job drawing both the knee and the hip into flexion together. So he really has nice motion there in terms of timing. That foot appeared to land more in a heel strike. It looks a little bit more like a heel strike here and then moving quickly to foot flat. That's the only heel strike we've seen on the video, so I don't feel overly confident that that's consistent. But either way, it's not too far out in front of the knee, so it's not in front of the body. We do see, again, in his back, a little bit of this arched posture, and then we see that the shoulders are drawn together, and the elbows don't quite come to midline, and his hands are in the same position. So from this view, in terms of risk for injury, good foot strike, good vertical tibia, good knee flexion, good swing phase. So all of those mechanics that are, and maybe normal vertical oscillation. So all of those things are not indicators for an increased risk for injury. His shoulder and neck and low back posture may cause some discomfort. Those aren't necessarily things documented in the literature for running injury risk. It's just my opinion. All right, so next we're going to see the back view. So again, here we see the shoulders being drawn together. So as we watch foot strike, let's go down to the foot. We do see some pronation here. I would consider that to be within a normal range unless it's problematic for this athlete. So a little bit of the heel tilted inward, but it's not excessive. Maybe a little more on this side, but the foot's in the shadows, so it's a little bit harder to see. And I think what's more noticeable in terms of injury risk than the foot strike is the crossover step. So when we watch that right leg, it crosses over midline. So if we consider midline to be a line that we draw down the body and bisect it, we see that the left leg is crossing over. The right leg does not appear to cross over. The left leg crosses over rather significantly here. So I'm looking here and you see the leg going this direction. I'm crossing over midline. And then as he slows down, it's there, it's present again. So crossover step is due to glute med weakness most of the time. Not always, but most of the time. And so as a reminder from the other videos, the glute med, you have the pelvis and the femur, and the glute med pulls, and you can imagine the air going both directions. And when the glute med is working really well, then it will draw the femur a little bit further this direction so the leg doesn't come over and cross midline. When he's loading on the right leg, we see a hip drop pattern. So watch here. We see the hip drop down this direction. We see the trunk and the shoulders shift this way, leaning to the side. This is a glute med weakness pattern as well. And again, remember that the glute med pulls down this direction in order to level out the pelvis, which would remove the need for a lean to the side. So the hip drop and trunk lean, the trunk lean is compensation for glute med weakness, and the hip drop is not a compensatory pattern. The hip drop is a sign of glute med weakness, but the lean is to make it easier on the muscle. On this side, we see the hip drop down, but we do not see the leg cross over. So on both sides, the angle between the hip and the femur are decreased from what would be considered normal. So on this side, the angle, it's the pelvis that's moving. On the other side, it's the femur that's moving. So both sides, that angle is decreased, but it's a different pattern that shows up, and it has to do with the glute med and lateral stability. So I'm working on glute med and lateral stability might be important for this runner in the future for injury prevention. Since we do see that right side trunk lean, so watch here, watch his kind of, his shirt, his trunk here, leans to the side, this direction. Leaning that way. That can stress the neck when you have so much tension in the shoulders. So because the shoulders are being drawn back and together, his paraspinals and his thoracic spine and his lumbar spine are working in moving him into extension. When he leans to the right side to compensate for glute med weakness, he's going to get a shifting of his cervical spine. So here, when he leans this direction with his trunk, his head is going to stay straight up and down, and so he's going to get a shifting to the side or a rounding, shifting in the cervical spine. When you carry tension in the shoulders, the muscles that attach the shoulder to the body attach to the rib cage, they attach to the spine, both the thoracic spine and the cervical spine. And so when you hold tension in those muscle groups, they compress down on the cervical thoracic junction. So if he's carrying tension in the muscles and then leaning to the side, he's potentially adding compression to the spine at a point where there's a little bit of side bending and translation, which may be uncomfortable. Let's see the front view. Is there anything we find that's different? So watch his trunk. One side moves all the way over to the other side. So I'm looking here at his shoulders. So notice the motion this direction. Moves all the way over to the other side. So We see the crossover step, and then we see the hip drop as well as the trunk lean. So those things are all present here, but as we're looking at the knees, I don't see anything different happening at the knees. So the knees look fine. It does not appear that he's moving into any valgus at the knee, so we don't see any extra rotation of the femur. In summary, from the side view, he has excellent foot strike, good vertical tibia, good knee flexion at initial contact and through loading. He has nice hip and knee flexion, a really ideal hip and knee flexion pattern as he swings his leg through. He maintains the pelvis and a little bit of an anterior tilt and his back in some extension, which may be because of stiffness in the hips, or may just be because he's holding so much tension between his shoulder blades and his thoracic spine. And so for breathing, he may be relaxing his abdominal muscles and relying on posterior chain muscles for trunk stability. This could cause some discomfort in the low back and or the neck and shoulders. So his arm swing isn't as fluid. He's missing some elbow flexion and extension and a little bit of shoulder flexion in his arm swing because of how he's carrying his shoulders. From the back view, this athlete has a number of patterns that are associated with glute med weakness, with a crossover step on the left side and a hip drop and a trunk lean on the right side. And so we would want to test that in the clinic, but I suspect that working on glute med recruitment or strengthening may be beneficial for injury prevention in this athlete. I think that's all I have for runner number 4. Thank you so much for submitting your videos. If you have any questions, please let me know. And if there's anything I can do to help you in the future, I hope you'll reach out. Thanks again for tuning in.